Appreciate everybody's attendance, and I think we have a topic this morning that'll be of interest to all of us. Keep in mind that for those of you who don't know, every third Friday of the month we have a Swedish CME conference. Those are usually good. Want to introduce Dr. Joseph Chang, who's the emergency room physician director, who'll give us a summary on settings in her current status of the OMC ER. A plug for next month's meeting will be a little bit of a different topic, which I like to throw in here and there. Our dear colleague Georgia Heisterkamp. Well, some of you may not know she's an art history major and one of our general surgeons, and she'll give a talk on sort of art and medicine, which I know she's been spending time preparing for next month. But with that, I'd like to introduce Dr. Chang and thank you for joining us, and thanks for all the work you're doing at the OMC ER.
Thank you. All right, good morning, everybody. So it's my pleasure to be here. So we'll get this presentation started. So a little bit about myself. And then I'm originally from Taiwan, and then I immigrated to the United States when I was 17 years old. So I am now going to UC Berkeley, and medical school was in Philadelphia. I also have went to graduate school at University of Chicago. I did my residency at Brooklyn Hospital that was affiliated with Cornell back then. And my most recent position was a hospital medical director in Doha, Qatar. I was starting a new hospital that's affiliated with the Cedars-Sinai, and that was located in Middle East. And then I also continue work as a physician consultant for the Joint Commission. So my previous career kind of went to New York and Texas and California. And then before moving to Doha last year, I was practicing Santa Fe, New Mexico. And then now I'm here. Okay, I'm still licensed in Qatar, luckily, so maybe one day I'll go back, so I don't know, we'll see. Anyway, a little bit of myself. And so today's topics, we're going to be talking about the people, the staff that we have in the emergency room, and then talking about our services that we're providing, particularly in terms of ED volume and those type of indicator. And I'm going to be talking about quality in terms of STEMI, trauma, and post-stroke and type of thing. And I also want to talk about our new staffing approach, as well as current projects that we're working on, as well as the next step that we are thinking about working on. All right, people. So, and then since the Sun Physician took over in October 2022, and as you guys all know, that we heavily rely on the locum staff, and obviously quite costly to the hospital. And as you can see from this graph, and we are actively and heavily recruiting permanent staff. So as you can see by the projection in September 2024, that we should be able to reach 90% fully staffed by permanent physicians, and as well as APPs. And we are definitely on track right now. Right now, the only opening that we have is actually about 1.5 FTE of permanent physicians. So who are these guys? So, and then we got our clinical teams, and they come with a diverse background, as well as from different parts of the U.S., as well have different kind of experience as well. So we all know Fred has been here for a while. He came from New York and did education in Columbia and Emory, and also that he has been 10+ experience, and he has been here since April of last year. So a new hire will be Debbie Holt. She's coming from California. Did a schooling in California, and she has a 15+ experience, and she is starting this month. And then we also have Rachel, and she's from Gig Harbor, Washington, and then she's one of the new grad that is going through our Sun Physician training program to become an APP in the emergency medicine setting. And then so she has started already, and she has been undergoing through our proctoring program within Sun Physicians. And a few other new hires, and Sandy, she's coming from Wisconsin, and she currently works at Mayo Clinic Health System, and then she has 20 plus experiences in emergency medicine, as well as her significant others, Andrew. They are couples actually. So also coming from Wisconsin and was working for Mayo Clinic, and then he also had 20 plus experience in emergency medicine. And another new hire that we have, and unfortunately we don't have the picture right now, Elizabeth. She is actually currently living in Washington State. However, she has assignment in Germany right now, and then she will be joining us in July of this year. And then she too has a 25 plus experience, and then she has also experience running observation units and then same day surgery clinic type of thing. So again, we got a wide variety of clinicians. So on the physician side, obviously you have me, and then also the couple of the new hire is Dr. Sandali, and then she is in residency at the University of Florida right now, and then she will be joining us in August. And then I think some of you have met Dr. Bennett already, coming from Michigan, and has 2 years experience. And then Christine Davis, mostly our night doctor, and then coming from New Orleans, and then did residency at Henry Ford Hospital as 15 plus years experience. So we also have a couple, 1 or 2 part-timer, which we just hired. Dr. Fowler, actually living in Seattle, and did a residency at University of Kentucky, and has experience about 10 plus experience in the emergency medicine already. And another night doctor, Dr. Zink, and then also, okay, I did not update that. He's actually coming from Michigan. I'm sorry, it's not Wisconsin. Okay, I'm sorry about that. And then he has been 10 plus experience as well. And another new grad is Dr. Katie Faulkner, and then coming from Mississippi, I'm sorry. Yeah, Mississippi, yeah, sorry. And then, so she will be joining us in August as well. So Dr. Watterson, some of you have met already, and also from state of Washington, and has 30 plus experience in emergency medicine. And then a couple other part-time doctors, they are local. So just in case somebody gets sick and so on, that we can use them. Dr. Makadakis, and live in Seattle, and also did a residency in Johns Hopkins University, and then 15 plus years experience. And then Dr. Oleg, and then actually is one of some physician medical director working in the eastern part of Washington. So he'll be working for us part-time as well. So as you can see, we got quite a variety of physicians between seasoned people like me, as well as a new grad. And I think we have very good team to the permanent team. It's some of regular part-time doctors going to help us to have a stable team. So we are looking forward with this strong team. We're looking forward closely to work with the OMC. So every doctor is coming on board, any clinicians coming on board always go through our orientation program, onboarding program, taking pictures and touring hospitals, and also they get to do 3 shuttling shift with our doctor. So just know the ropes and also understand the ins and outs of working at the OMC. So let's talk about service, what we are doing these days. So before coming here, I know that OMC ED is quite different from other hospitals, and in terms of the patient characteristics. And so we have 79% Medicare, Medicaid, compared to the average U.S. hospitals, so usually about 45%. And our patient population, 60 and older, and that we think about 46-ish percentage. And then by the U.S. hospital, about 20%. And then so admission rates slightly higher, and the transfer rate slightly higher as well. Again, it's because of our demographic and as well as the patient population we are serving. So as you can see, the patient that we are serving is actually particularly sicker, and also that has a lot of social detriment type of thing that we have determined. Sorry, those determinants that we have to work on. And you can also look at the average, the chief complaint of that diagnosis you see in the average emergency room. You get a lot of abdominal pain and the URIs and the non-specific chest pain type of thing. Those are typical you will see in the regular ER. However, in our ER, the top 10 primary diagnoses between 2022 till now, as you can see, we see a lot of chest pain And then we see some abdominal pain, we got see a lot of fall, COVID, those type of issue. So it's quite different from so the point is that this is not your average typical rural community ER. So it's a little more challenging. So this is what we have seen in these days. From 2022 January until now, we are average about 66.6 to 75.5 patient a day. So this kind of has some seasonal cycle type of thing as well. So you can see this obviously is post-COVID, and we can see that our volume pretty much holds the same, more or less. So in terms of arrival pattern, so you can see that at night. So this is the diagram is actually from midnight till midnight to 11 o'clock at night. As you can see, there's this pattern pretty much typical for any ER, and then it's kind of a little bit slow overnight. However, it picks up around 8 o'clock, 9 o'clock, and then go all the way till about 10 o'clock at night. So this will be a typical ER arrival pattern. It might make sense to you that later on the reason why I present this picture, because I want to tell you more about the staffing pattern that we're gonna have. So there are several initiatives that's led by the nurse, and then actually help us to increase our efficiency. So as you can see from this diagram, around August 2022 that we start a provider in triage model. So what it is, we use the APP to become the provider in triage. So all the patients present to the emergency room, that they will be first seen by the triage by the nurse, of course, and then they will be also seen by the provider in triage as the first touch. So they will take the brief history, and then they also will place the order appropriately to kind of screen out a sicker patient, basically. So by doing that, that reduces our door to clinician time significantly. And then so we are around about 15 minutes-ish right now these days. And this is data, it's the latest data coming from the EPIC. As you can see, that the national standard is we will consider excellent if can reach door to clinician time less than 30 minutes. And the best emergency room in the US is less than 10 minutes. And then we are almost there, so we can claim that we're actually getting there to that direction. And of course, with door clinician time reduction, also help to reduce our length without being seen. And the national average is about 2%. As you can see that we are, these days, we're consistently below 2% left without being seen. So, however, there's definitely something that we continue to want to work on is our median length of stay is quite long. I think the challenge of working in this environment is because of lack of certain specialty support, and also a lot to do with the ED throughput type of issue. These particular issues that we are working on. And the national average is about 194 minutes, and then we are pretty much at 280 minutes for our typically length of stays. So we want to delve into deeper to find out what kind of patient that led to this prolonged length of stays. This is, again, it's the median time. So for admitted patient, our length of stays, as you can see here from EPIC data, is around 400-ish, about 500-ish, around that range. As you can see, it's a little bit upward trend. So, and this kind of an issue that we are working closely with the hospitals group and try to figure out what we can do better. And again, we are above the national average, which is 240 minutes. And in terms of discharge patient, again, we're not doing that great either. Again, national average 208, and then we are around 280 minutes. And then this is the patient that's seen and discharged. But then again, that's due to the limitation of our physical environment, as well as our staffing, and particular nurses, and that's definitely a lot of limitation factors that we are working on. So the biggest challenge is actually transfer. So I don't have the national average in terms of a transfer. However, you can see that this is January. So as you can see that we are hitting 800 minutes average median time to transfer a patient out. Again, transfer is quite challenging because we don't have any locally, we don't have a lot of specialty support, and also we rely on UW and Swedish, all those people that to help us to accept this kind of patient. So again, we are dealing with elderly population with multiple medical problems as well as a lot of cancer type of related issue. Those all pose quite a challenging challenges for us to transfer this patient out. And this is something that we actively working on and try to streamline the process. However, we really rely on other hospitals' mercy. If their hospitals are full, they're not even taking people on their wait list and so on. And I have not had experience transfer patient out of state yet. Have we done that yet?
Rarely.
Rarely.
It's really rare.
During my tenure in New Mexico, we constantly transfer patients out of New Mexico, send it to Colorado, Texas, and all the different places, even California, naturally. So I guess luckily that we don't have to go there yet. But if all else fails, then probably something that we're going to be working on too. So
Our cath in Victoria, 18 miles away.
well, Canada, yeah. So
Except there's a wall.
yeah. So this is one of the bigger challenges we're facing in terms of a transferring patient. So let's focus on quality a little bit. So there are several core measures that we are looking at in terms of sepsis. Okay. So again, there's a lot of nurse-led initiative, and thanks Aaron for doing this wonderful job. Ever since that we started the COPE sepsis, call overhead, that we are able to. This is data only up to the second quarter in 2023, and then we're still calling data for third and fourth quarter. As you can see, ever since that we start the COPE sepsis overhead, that we're able to reach the double our compliance rate to the sepsis core measure, and we are looking forward to continue working with the nurse to actually increase our compliance rate. And the goal is actually the national average is 60%. So we're almost there. I think some of the better hospitals were able to do 80%. So again, we try to take a baby step at a time. Then we try to reach the national average first, and then maybe to reach the standard to one of the better hospitals. So some of the more recent fallouts is actually antibiotic administration time, blood culture, and the particular repeat lactate level. So we are working closely with the IT team as well as the lab, try to find out a better way to do automatic reflex type of order. So this is something that we are working on. So we identify the areas of improvement, as well as we are focused on how we can do better. So in terms of a Taylor Neuro, and actually is one of the great things that we have here. So we were contracted for, originally when we started, we were looking for 240 cases per year. However, we actually almost double that actually. So we heavily utilize them for our Taylor Neuro console. As you can see that from within 1 year, 2022 to 2023, that we actually used for the stroke-related consult is at 412. Actually, as you can see, again, it's purely because the elderly patient population with a multiple medical problem that led to stroke, basically. So we also utilize it for other neurological consult with dementia, or maybe Guillain-Barré, those type of things. We use them for that as well. Actually, it's a great resource that we have, and then we are definitely very much appreciated. And then we are definitely looking forward to the more administrative support, continue to utilize service, particularly for the patient population we're serving. So for the usage-wise, and this is the data coming from the Swedish hospital. This is what they gave it to us. As you can see, it's kind of no particular pattern to it. And some of them they recommend you skip a thrombolytic. Some of them I don't, and mostly they don't recommend a thrombolytic. Again, one of the core measure is really door to needle time. So the CMS core measure wants us to try to from door to needle, and then within less than 90 minutes. And then our current average time is 73 minutes. This is the data given from Rachel. As you can see, we are also on a slightly downward trend right now with a couple outliers, and that was in 2022. There's another outlier is in September 2023. I had not looking too deeper to find out what's going on, but it's something, and then some of them is due to delay identification of a stroke and so on. So anyway, so something that we're looking to. And it's overall that we're on a downward trend. And as you can see, our average time is about 73 minutes, which is below the core measure. However, the latest AHA recommendations, actually, they want 50% of the stroke patient from door to needle, and 50% of that, they want to be less than 60 minutes. And it's definitely the bigger goal compared to CMS core measure. However, I was looking to the Washington State where the statistic, some of the hospitals were able to reach that. So anyway, something that we again, baby step, which is reach the CMS core measure first, and then we're going to focus on how we can do better. And then with the cold stroke and with clearing out the CT, as well as a speedy teleneurologic consultation, I think it's definitely possible for us to get there. As again, you can see 73 minutes, we just need to shave about 13 minutes and we'll be there. Again, this is stroke data compared to, this is from the Swedish hospitals as well. So they are comparing us, again, we are about 73 minutes compared to my previous state, New Mexico, is much worse. But the Washington State, actually, most people were able to reach about 63 minutes door to needle time. So this is definitely the goal that we are striving for. So in terms of STEMI, and then we have a new process that went live in September 2023. And again, we are trying to reach the goal is the door to inflation to balloon time in less than 120 minutes at the St. Michael's Hospital cath lab. So we have so far, since September until now, we have 4 total STEMI cases, and then 3 of them were under 90 minutes, and 1 was 140 minutes, and then still it's below 120 minutes is our goal here. So the new process that we have is actually and when the ED physician identify the patient with STEMI, and then we'll call St. Mike's and right away, and then tell the nurse supervisor that, hey, we're going to transfer a patient to you for STEMI, co-STEMI. So our ED physician was able to initiate co-STEMI in our ER, and then with St. Mike, auto accept at St. Mike's. And then so next thing we do is we have a big blue button in our next to our clerk, and then push that button, and then the Lifeline will come within 5 minutes and to pick up a patient and load the patient and send him to St. Mike. So, and then once a patient enrolls, then we'll try to talk to their house supervisor as well as their cardiologist regarding the STEMI case we're sending to them. So then they will decide whether or not the patient should directly go to cath lab or go to ED for further evaluation. But it would not cause delays from our end to sending the patient to them. So this is actually, there are still some revision to the process, but that's current process right now. As you can see, we have 4 cases, and then we're able to reduce that to below 120 minutes. That's a STEMI. So intensive trauma, again, we are a designated level 3 trauma center, and Dr. Bundy has done a wonderful job keeping this trauma center going. And then, so we have a 591 in the 2023, we have 591 total trauma registry cases. And then 285 was a modified trauma, and 23 were full trauma. So as you can see, this 2 number does not add up to 591. But the other thing that would register trauma, it does not necessarily fit in the criteria for full trauma versus modified trauma. There are other trauma type of category, and but it still goes to registry anyway. So out of all those, and then we have 129 transferred to Harborview. Again, we have auto accept a program with agreement with Harborview hospitals, and then so we just send a patient to them. So it has been pretty smooth the process wise. And then another thing that we're looking at is mismodified trauma. So we have this criteria for modified trauma. Sometimes patient came to ER that initially that we did not identify this should be falling as a modified trauma type of cases. And later on, with the retrospective review, and then we found out that there should have been a modified trauma. So this is one of the projects that we're working on, trying to reduce the number of missed and modified trauma. So patient experience is another thing that we are working on. And then again, this data is based on PRES scanning, and then we only have the data up to Q3 right now, and then 2023. So this is purely based on the patient experience, and particularly in the category of courtesy of doctors. And as you can see, in the Q1 only 50%, and then Q2 was 54%. So this is something that we are working on, such as, so there are several measures that we instituted, such as asking doctor to sit down and to talk to the patient, as well as set out expectation, approximately how long the test is going to take and how long patient is going to be here, as well as give them constant feedback and updates about what's going on with their care. So this is something that we're working on, and hopefully that we can continue to increase our numbers of courtesy of doctors. So, okay, I'm going very fast right now. Maybe stop for a second. Do you guys have any questions? Sorry.
Yeah, from the general surgery department, in trying to improve these sort of length of stay, time to admission metrics that we're kind of not doing as well on, is there anything that we could do or you could ask of us to help you out in improving those care metrics?
So that's going to be a next step thing over down there. So we are looking into the other step. The other thing that we are thinking about looking into is such as consultant response time. So because right now we don't have a very robust system looking into how quickly when we call from consultant versus they call back. Again, there are many factors to that. Why consultant, you could be in the OR busy, and somehow we are waiting for the CT report and this and that. So there are many steps before we get there. So again, we just try to tackle one challenge at a time, and this is something that we are thinking about looking into in the future. It's something we can look into. Yeah. So again, we actually for most specialties we're appreciative when we call, and then usually unless you're busy in the OR, then usually you guys call back pretty quickly, and then some of a consultant even before they leave for the day, even come through the ER to make sure make sure that everything's okay, and then provide assistance as needed. And the other day, Dr. Lawson came by, and then when I was in the hospital, and they say, "Hey, I saw somebody with a fracture. Do you want me to take a look?" And then before I go, I say, "Yeah, sure, it'd be great." Yeah. So those type of things. And again, I definitely feel a lot of collaboration, very collegiate environment, and I appreciate that. But we just need to look a little deeper about what else we can do together to improve our length of stay.
So I just have a follow-up comment to Sam's question or comment. That, sometimes the delay seems waiting for test results, especially, general surgeons get consulted a lot on abdominal pain. And so sometimes, CT scan is a very common part of that workup. But I've had several occasions, more recently since the transition to sound, where the report is back and on the chart, and it can be 4 hours before I'm called by the ER provider. And I'm just wondering, what is going on? Are they just so busy with other patient care that they're just not, following up, or, and so then, it turns out to be, a lot of times the report's back at 7 in the evening and I'm getting called at midnight. And sometimes these are patients where it's not like classic appendicitis or something, where it's just a slam dunk, but they're just, and I just don't know what's going on, during that interval time, because the report's back. And I know a lot of times they're waiting for the report to come back before they make a decision in terms of what to do.
Yeah, sometimes the patient may not even have had the chance to make it back in the ER. They could potentially still in the waiting room. So some of the tests, the provider in triage model, they'll initiate all the orders, and while patients still in the waiting room while waiting for the room in the ER. So again, if there's some critical results, and then usually the radiology will call us right away. For the lesser one, usually it's not until the the patient eventually make it back to the emergency room when they review all the results. That's what we discover. Okay, that's one potential explanation, but I'm not. I think it would be better for us if anything like that happened to a patient. Please let us know so I can look into it and find a way to improve. Yeah, usually for critical result, the radiology will call somebody right away. So if it's not critical result, usually that may, unfortunately, I hope does not happen that often, may get lost in the system. Yeah. But it's not until the patient make it back until somebody review the result.
Does ER length of stay, does that clock start when they're seen by the provider, when they arrive at the door, when they get a room?
Arrive at the door.
Okay.
Yeah, that's when the Department of Health has made very clear to us, the moment a patient arrives, as soon as they're triaged, they are an emergency room patient that need to have the routine vitals per ER protocol and so forth. So we've expanded our heads around what is the ER out into the waiting room, and had to figure out privacy, HIPAA, where to get an EKG, where to get a quick screening exam, how to do this vertical triage that they've been working on, and it's ongoing.
Yes,
as you said.
Yeah. There also the potential renovation project. Maybe you can create sub-waiting area once patients triage and the initial order started. They could put in a sub-waiting area while waiting for the result, and then also that having another provider to monitor and constantly go through result and so on. Make sure there's nothing that need to be acted on right away.
I mean, it includes somebody who's suicidal that comes in. Do they have a gun on them? Do they have a knife? Do they have a weapon? That starts in the ED, in the waiting room now. Whereas before we were not as closely surveilling that piece. We need to make sure people don't elope and without being seen with risk of harm to themselves or others.
Yeah.
There's a lot of reasons, as you're pointing out, Dr. Chang, for these delays and this dissatisfaction that results from the delays. Some of you may or may not know or may be interested. There's a white paper that's just been written and published by the Washington State Hospital Association talking about the ER crisis in the state of Washington. And some of the points of this white paper are more germane to bigger urban hospitals, but some of the points are very germane to rural emergency rooms. There's many factors, but one thing that, and maybe this is more leaning towards inpatient providers, surgeons, orthopedists, and certainly hospitalists, is I understand that we've gotten to the point where now it's very difficult, if not impossible, to just talk to a tertiary colleague about a perplexing problem. You can't collaborate about a perplexing, but to the point where I believe one of my orthopedic colleagues told me recently that MedCon at UW has been abandoned. And so that really speaks volumes of our ability to collaborate about difficult cases, some of which after collaboration may not need to be transferred. So just take a look at that white paper, folks, if you get a chance. It'd probably be on the State Hospital Association website. It's pretty graphic, actually.
I can put a copy in the Med Staff Lounge.
Larry Gordon, I can't raise my hand from my phone. I was wondering how many patients that are seen in the ER could have been seen if we had an urgent care center.
Well, we discharge about 75% of patients that we see, so it's always hard to put a number into it, and I would say probably 25%, but we constantly get patients sent from walk-in clinic to ER for evaluation too, so they're kind of going back and forward. So I would say, again, my rough estimate, probably 25% of the patient could be seen in urgent care, which we don't have right now, yeah.
So when you think about large volumes and difficulty handling patients and triaging, it'd be interesting to see how the finances would work out if we had an urgent care center.
Yeah, we've worked that up a couple of times, and I think that deserves continuing intermittent workup, just for the reasons you mentioned. The regulations around proximity, ambulance access, and then the finances and how you staff it. But really good point.
Thanks, Scott.
All right, any other questions before I move on? Okay, so I want to talk about our new staffing approach. So the previous staffing model, actually we have new staffing model that we started in February, which is a couple days ago. So the original staffing model, we have 44 physician hours and then 12 APP hours, and mainly cover for the providing triage. So that was totally 56, total clinician hours. So the new model that we embarked on is we have 36 physician hours and 24 APP hours. That gives us total clinician hours about 60. So slightly increased by reduction of the physician hours. So the new model, the previous model, as you can see, that there's a kind of a is a range between 11 hours, and 12-hour shift, and as well 1 12-hour shift. And so you can see that it's kind of a gap in terms of continuity. Because one of the concern that many medical staff raise is that sometimes they talk to the ER, they're not sure who's in charge, who's leading the ER per se, who do they talk to? So this new model that we embark on is has this lead physician model. So basically one physician from 6 a.m. to 6 p.m. For that 12 hours, he or she was a leading physician that will constantly, there's a team leader, so to speak, and is constantly monitor what's going on in the ER, as well as continued communication with charge nurse about the throughputs and the patient flow and what kind of things that we're waiting for, and how you can help to push the patient through the system. So there's somebody in charge from 6 a.m. to 6 p.m. So it's another one who will take over from 6 p.m. to 6 a.m. So that's another physician that will be the leader. And then we have one APP coming in from, actually, I'm sorry, that was a mistake, 9 a.m. to 9 p.m. So for 12 hours, this APP will be working in the ER and along with the physician, helping the physician. And then there's another physician coming from 2 p.m. to 2 a.m. for another 12 hours, provide assistance. And then we continue going to have another provider in triage, since that model works pretty well in terms of a provider to clinician time, as well as reducing our left without being seen rate. So we're going to continue that. So the reason for that is to try to match up with the arrival pattern here. As you can see, we can start getting busy from 8 o'clock and 9 o'clock and kind of slow down a little bit. So that way, with this kind of provider model, as you can see, that provide adequate coverage in terms of the surge and the patient arrival pattern. So there was some question about the capability of APPs. So again, we have some physician has a very established and evidence-based type approach in terms of APC onboarding. So for the new grad, they will go through a training in terms of mentoring and proctoring and emergency medicine boot camp for the procedure and so on and so on. And then there's a stepwise approach for the new grads. However, for those more experienced APP that we got for the 4 additional APPs that we got, and then they are very experienced, so they don't have to go through that kind of training. However, they're still going to go through the mentoring shift with the physicians, as well as be closely supervised. So again, our APP, they can, once they reach the staff level tier, they can see ESI 3 and 4 and 5 independently. And then we'll continue to monitor whether it's chart review or in-person observation in terms of what they can do, how they're doing, and then in terms of the management. For ESI 1 and 2, they may see those patients, however, they will be under supervision of a physician. So the physician will attest to their notes as well overseeing their care. So this is the approach from the some physician, and then I working closely with Dr. Hesterkamp and then try to more finalize in terms of OMC policy about the APP, their privilege delineation. I think there's something that we are proposing along to this line, and we particularly want to look into a certain procedure, high-risk procedures such as intubation, conscious sedation, those type of things. And those are something that we're working closely. Right now, they're not doing those. And then once we establish some criteria, and then also to the level of competency that we're comfortable with, and then that's something that we'll embark on as well. Again, they're not doing any of those procedures yet, and then we are working closely with the OMC medical staff and the credentialing committee to work on that. So again, this is a new approach that we have. It's more a team approach, and again, it's the high risk patient. They will be very closely supervised. Does anybody have any question about this approach?
Could I mention?
Yes, please.
Some of we really look for experience in our APPs as we've watched the recruitment. And some of the APPs are working independently in ERs by themselves in other states, previously where they're doing these procedures in a less busy zone, but are responsible for a whole bunch of procedures already. And that's why we look at that here. It hasn't been our typical, approach in the past.
Anyway, does anybody has any questions about new model? All right.
Yeah, I do. My initial experience has been that I was called by APPs twice for admissions that they didn't review it with their supervising staff, and there was significant errors that occurred. So I'm wondering how that process is going to be improved.
So in terms of ESI 3, 4, 5 type of patient, so they are practicing independently on those cases. For 1 and 2, the expectation is they will be reviewing that with the supervisory physician. So I think probably, Dr. Gordon, probably best we talk offline and then send me those cases and we can talk about it and then see the particular area concern and then we can come out a better way to approach. All right, any other questions, anybody?
Can you define the different ES levels?
ESI, so Emergent Severity Index is that's a triage system and that's used by about 70% of the US ED. So it's really resource-based kind of utilization review for people like, obviously you are full trauma and those type of things, those typically ESI 1. So people present the ER with a psychiatric problem because of the resource they utilize tend to be ESI 2 type of thing. People come in with a regular abdominal pain and with a stable vital sign, they kind of within the ESI 3. But of course, the people sepsis and so on, elderly with abnormal vital sign, and then they'll come and go into ESI 2. So it's really more the resource-based type of, they'll go based on the chief complaint, based on the vital sign, and then based on the resource they potentially use. If they're gonna do lab, they're gonna do x-ray, they're gonna do EKG, those type of things. So those kind of determine in terms of ESI.
And who assigns the score?
Nurse.
The nurse does?
Yeah.
Okay.
Nurse will go through training and then their competency will be monitored in terms of those kind of ESI. The physician does not downgrade or upgrade the ESI level, we just see the patient basically.
And does that get reviewed periodically?
By the nurses,
for
yeah.
accuracy? Because obviously there's a distinction between 2 and 3 if
Sure.
one requires review by the attending and the other does not.
Correct,
So,
yeah.
make
So
sure.
usually the nursing will do that, and then since we embark on this journey, and then we definitely something we're looking closer with the nursing as well. Yeah. Okay. Any other questions?
When you, would it be possible when you're looking at the various metrics of length of stay in the emergency department, recognition, sepsis, all those benchmark numbers, could you look at the difference in time based on the provider who is directly involved in the care of those patients?
I think it's possible. Epic has pretty good. I'm just learning to use the dicer as well. Should be able to narrow down to that level. Yes, because right now Rachel is looking to a lot of sepsis data, and then we try to kind of narrow down all the way down to the provider level to see who are the outliers. But the challenging part of it is sometimes the patient could be still waiting in the waiting room without being showed at ER, and after say 90 minutes, whatever, and then finally make it back to ER and I pick up the patient, then my time is gonna be not as good compared to other people. So it depends, quite a few factors, but again, I think the key thing is to identify upfront in the triage step, and then all the order initiates, you can see is door to antibiotic time, lactates, repeat lactate, blood culture before antibiotic, those type of things. Those actually could be done rather, it's pretty much protocol driven, so it should be rather easy, but again, we try to, I just arrived 5 months ago and tried to figure out what's going on here, and then once we identify the problem, and the next time we find out what the problem is, and the area of improvement, and then it's something that we can pinpoint down and then work out. Yes, to answer your question, yes, yeah, we can definitely go down to that level, yes. Yeah. Any other questions?
Looks like Dr. Cunningham has his hand raised.
Yes.
Hello, good morning, Paul.
Hey, good morning. Can you guys hear me okay?
Yep.
Yeah. Hey, thanks, Dr. Chang, Paul, and Jamestown. Hey, I want to harken back to Dr. Fisher's comments about the white paper and collegial collaboration. And we can do this offline, but I just want to bring it to the attention of the group of what we can expect as far as peer-to-peer communication. So, for example, anecdotally, last week I had a guy with chest pain. I did a pretty good workup, EKG, chest x-ray, got some labs brewing. I even reached out and spoke to one of the OMC cardiologists, decided to send them in. And how would the ER, you don't have to answer this now, but I like to align expectations, especially with all the new staff coming up, of how you would like us to communicate to your attending the pertinent aspects of it. I'm perfectly okay with a system where we talk to a nurse and they pass it on, but I do want to make sure that when I see my patient is in the ER 2 hours later, that they're getting, in this case, a rule out, which is what myself and the cardiologist expected. So how we can communicate and what we can expect to see in the note that you've seen that communication. Thanks.
Okay, this is definitely something that we're working on as well, better communication. So ideally, now I would like to see the physician-to-physician conversation, and so again, busy ER, and then we just need to find a better way to communicate. And I definitely will talk to you offline, and then there are several things that we're working on, and then we hope that can solve some of these problems. All right, any other questions? All right, I got 13 minutes, okay. Okay, current projects we're working on. So this is something that we talk about. So we would like to streamline the admission process, and then we hope that we can establish some of that through the service line agreement with other departments, and then with the surgery, orthopedics, and so on. Things like hip fracture or some gallstone pancreatitis, those type of issue that we're gonna try to figure out what's the best way to take care of our patient, and without necessary cause of prolonged length of stay in emergency room. And then, so we are also working with the family medicine residency, and so hopefully that we can even work on with some of the emergency medicine service, a rural emergency medicine site for some of the bigger academic medical centers, so that we can actually kind of also elevate our the knowledge base. I mean, the best thing to learn is to teach. So hopefully that we can do that as well. And then we are working closely with Dr. Kennedy's and so a lot of people in terms of vulnerable patients workflow. And again, having the patient with behavioral health issue is quite challenging in the ER, particularly with the challenge of the Washington state law in terms of what we can or cannot do. Is something that we need to clarify further. And we are working on hiring a patient navigator to do follow-up with the patients, as well as to provide some kind of aftercare follow-up, and then also the communication with the community physician and so on. So this is one thing that we're working on. And we are also working on the interfacility transfer process. So maybe we can streamline the direct admission from the surrounding area hospitals as well as clinics to admit the patient to our hospital. And again, we are talking about the better communication with the hospitalists and as well as the community physicians. And then we were talking about ED renovation. So one idea is to really try to create a sub-waiting area and then kind of separate between people waiting to be seen versus people who have the workup started already, and also so that we can monitor their laboratory and then the imaging test result as well. And then we're working on the finalized APP privilege delineation, and then some physicians also try to do some kind of community outreach in terms of providing fundraiser as well as sponsor community events and so on. And we're also thinking about doing the nurse practitioner training program, and then so we can buy more APP down the line. And then we are also working on the social admit process. And then there are certain old charts, and then we try to work with the medical record that's as old as 3-4 years old. Then we try to finish them up as well. And then we also want to work with our walk-in clinic in terms of a referral process, exactly what Dr. Connie had mentioned, that we want to work on better communication in terms of what the concerns are, why the patient is sent from walk-in clinic to the emergency room, so we can address those concerns appropriately without dropping the ball. So those are the work in progress. For next step, this is something that we're working on in the future ideas. We like to work on, try to look at our door to room time, ED room time. So this is exactly what Dr. Heskett mentioned. Well, why does it take so long for the CT result? So we want to work on the door to room time. Again, we are limited by the physical space that we have, as well as the nursing staff, as well, provide a staffing model. So we are something that we're working on, and we want to look into further, and then find a way to reduce that as well. And then we want to look into the admission decision to depart time. Again, this is something to do with the streamlining admission process, better communication, so taking care better our patient. So we want to look at to clinician perspective of job satisfaction and the nurse perspective of job satisfactions. Again, we are here, and then we want to make sure we can retain to our staff as well as increasing morale. That's something what we want to look into. And also we are looking at the relationship as well as the consultant responsiveness. That's something we're going to look into. And then as well as the medical staff perspective of ED performance. We don't be just a little group that are just doing our thing without communicating with others. And then so this is something that we want to work on in the future. So again, this is going to be things that we will work on currently. We got quite a few things on our plate already, and then we're going to do those first, and then eventually we'll work on this. So quick summary. So as you can see, the staffing wise, we are on track, and it will be 90% fully staffed with our permanent physicians, with some part-time doctors. So once we have a stabilized group, and then we'll hope that we have more meeting, that we can meet our medical staff. So again, a lot of things coming through the networking and also get to know each other. So we are comfortable with each other, and then so we definitely will be easier in terms of talking about cases and finding out the best way to take care of patient together. So we are on track to reach that percent. The reason for 90% is we want to have 10% about opening so that we can have some part-time doctor, locum doctors in case, again, with a small group, if one of us gets sick and then there's a difficulty get coverage, it cannot be all me for covering the whole ER. So then we're gonna try to work on that so that leave that flexibility as well. In terms of service, as you can see, that we are I guess I would say the flagship hospital in Peninsula, basically. So we want to take care of all our community, our patients. Again, we are working on, as you can see, our left without being seen is quite low. Again, the key thing is to get those patients from the waiting room into our ER, and it's something that we are working on. In terms of quality, STEMI, sepsis, and then trauma, and then stroke, those type of things. Again, we are moving to the right direction, and also we are working on patient experience and so on. I mentioned about the new staffing approach, and then I would really appreciate your feedbacks in terms of how we're doing, and this is something that we experience on, and we will see how it goes, and we'll tweak it to the way that I really appreciate your feedback so we can tweak it to the way that is make it better. So there are several projects we're working on. There are several projects that we would like to work on down the line. And again, I really appreciate all your feedbacks and suggestions how we can do better. And I'm here, and I bought a house in town, and I'm planning to stay for a long time without being fired. So hopefully I can work with you guys closely together and then make the OMC ED better or make this community healthier. And that's it. Thank you for your time. I'll be happy to take any additional questions that you may have.
Any questions, Sid? Go ahead.
I have just a comment, Larry, again. I wanted to thank you for all the work that you've been doing with the ER physicians. Communication between us has improved quite a bit over the past few months, and it's very collegial now.
Thank you, Dr. Gordon. And thank you for the kind word, Dr. Cunningham.
I have two quick questions. This is Mark Fisher. I understand this great model of patients being triaged within minutes of arriving, and some tests are ordered. But my hunch is then there may be a gap after that initial assessment where the patient's just sitting there for a while and doesn't sort of know what's going on yet, and this and that. Do we have sort of a circulating ambassador that is sort of assuaging patients continuously, checking in on them?
There are several things that's happening. So number one, we have a patient experience person during the day that we're circulating around the ER to check on them, make sure they're okay. But this is a non-clinical person.
Yeah.
The second thing that we are working on is with Aaron, our nurse manager, is a communication tool. I forgot the name of it. It's really, you're pushing the message to the patient, to their whatever device they have.
Kind of like the Outback restaurant.
Exactly. Hey, you're up there, your lab test show this, and this is this, and you're waiting for this, and so on. So that kind of update through their own device is something that I think we're talking about purchasing and working on to push information to them. And then there's always the triage nurse out there, we have to monitor them, make sure nobody getting sicker while waiting.
Yeah.
How often do patients leave after they see their test results while they're still in the waiting room?
Actually, it's also less than 2%. So I did not show this, we have one was left without being seen rate, and before triage and after triage. So we have another data, it's actually below.
Yeah, so
I didn't show it's below 2% as well.
Yeah, we call that elopement.
Elopement, yeah. Yeah, because they say, I got a twisted ankle, oh, okay. My chart says I don't have anything broken, I'm out of here, yeah. So,
Yeah.
But they still seen by the provider in triage, so they were seen by the provider. So the goal is, obviously nobody left without being seen, but again, less than 2% right now, yeah. Any other questions? Yes.
Yes, Larry, again, I have one more question. Are you reviewing the tests that are ordered in triage to see how often they are inappropriate or appropriate?
So that's something that we're working on as well. Unfortunately, when provider in triage, they can kind of use the standardized order. If coming with abdominal pain, they will order this, and chest pain, they order that as well. But we don't have really strict guideline in terms of what they can or cannot order. So unfortunately, some of the unnecessary order will enter because it really purely depends on the physician the provider who later on see the patient. They will determine whether or not those maybe additional order will be entered. Maybe they think certain orders they thought will be inappropriate based on additional histories and physical examination they perform. So it's really, unfortunately, people dependent as well as the brief history and physical that was performed and what was ordered. So sometimes they end up order more than necessary in order to, again, they try to catch the wider net because they miss certain things. So it's going to be something that we have to look into further down the line. So right now, because the patient population we're serving right now, we try to not to miss the big things. And again, in this patient around here has many medical problems. You could have a liver laceration, just happen to have a heart attack, and happen to have something else along the line. And it's quite challenging, and then we'll continue to review that and come out more simple and streamlined type of protocol in terms of what they should order. But on the other hand, we also want to leave the flexibility for provider in triage to have the flexibility to order things they think that's necessary. So again, it's double-edged sword, and we don't want to miss too many things. On the other hand, we don't want to over-order and then not reduce unnecessary radiation or cost to the patients.
So something we've been working on with the general surgery service, just amongst ourselves, is trying to come up with like consistent sort of flow admission protocol patterns for like one thing we've been working on is like a small bowel obstruction, and when like a general surgeon should come in and see him right away versus when we can have like a hospital admit him overnight. You mentioned you're working on a similar thing for gallstone pancreatitis. Are there any other conditions that we could start thinking about and bang around with each other that you think that sort of approach would be helpful in throughput?
Well, so again, this is gonna still very early stage, and I want to look at all the diagnosis, and I try to pick out the low-hanging fruits first, something easy first. So this is one thing I can think about, and then some of those the patient require ERCP, those type of things. Those kind of, somebody will come in here with a gallstone and dilated common bile duct, and they say, oh, I gotta wait for ERCP and in the morning, and then so that takes a while, and it also depends on the availability, Dr. Lego and so on. And then, so right now I try to narrow down the top 10 diagnoses that is the longest length of stay, and then try to tackle them, try to find out a way that, okay, what are those, and then how can we reduce the length of stay for those particular cases?
Yeah, I agree. Gallstone pancreatitis is definitely one that ends up getting pinballed around from us and wasting a bunch of time.
Have you talked to
all,
surgeon? Have you talked to GI?
Yeah, if we could have come up with a more like, if we could all agree, like, yeah, this is the flow, this is the way it should go, yeah, that certainly would help. So yeah, if you identify any other conditions like that, let us know. We'll start working on it amongst ourselves, because it's hard enough to get all 5 of us to agree on how we want to do it.
Yeah, it's gonna be, yes, absolutely. And also agreement with the hospitalist group, and it gets challenging, but again, one good thing about OMC is that everybody's easily approachable, and then we can definitely talk it out to find out this agreeable amount of us. So.
I have another, just a comment, and I think it's relevant to the ER, but maybe more relevant again to the inpatient setting. Some of you may or may not be familiar with the BREE, B-R-E-E, BREE Collaborative, which is a institution in the state of Washington, very robust institution tackling the most difficult problems that we have in the medical arena in our state. Some of you may also know or remember when I used to be a doctor that I was a nut about discharges and transitions. Well, it turns out on February 29th at noon, the BREE Collaborative, if you look it up and click into it, February 29th at noon, will have a white paper streamed update on the complex discharge. I actually wrote them a letter, told them I thought they should change the title of their topic, because there's complex discharges, but I think what's caught an attention to complex discharges are delayed discharges. And not all delayed discharges are medically complex. I don't know if they bought my logic, but nevertheless, I'll bet you that complex discharge session later this month would be very interesting to many of you and maybe germane to some of the workflow in the emergency room.
Absolutely, absolutely. Well, I'll definitely look into it as well.
Yeah, thanks for forwarding some of that a month ago or whatever. Our case management, I forwarded the white paper to them, the preview white paper to our case management, and it's going to be worked together. And with that, what they're looking for is they're looking for the state to have a unified definition of what is the complex discharge patient. Whether you adopt the best practice guidelines or not, do we have a common definition so that you can work and get data and get the big data over time across the state and work the problem.
Scott, do you have any other closing comments or anything here, just for a moment?
Well, I just want to say we've heard an excellent presentation. Thank you very much. And that I just will tell you the kind of the character and the quantity of the work behind the scenes that Dr. Chang has brought to the table with the sound team is reflected in what we're seeing here today, and it really is ongoing work, as he said. And one thing I've really appreciated is anytime I've heard a concern or passed on a concern, he immediately goes to work on it and makes himself available to work with the various teams. This thing with single bed cert, which is so complicated, and social admission, and just that communication. Dr. Gordon and Dr. Chang are talking regularly and planning regular meetings ahead as well to work issues. But I think the surgeons, general surgeons, orthopedics, primary care, the walk-in clinic, these are all opportunities for conversation. And what we see here is a very systematic approach of trying to define where are we at, what are the issues, where are the opportunities, what's going on nationally or regionally, what's the regional standard that we should be doing for the things that we can do well, and how do we approach that? Because with that information, we have better leverage to prioritize where the spending goes, where the effort goes, because we know the bandwidth and the resources are limited. But these are all opportunities, and if you live in the hospital, you hear code sepsis, code stroke quite frequently. Maybe we'll change the way it's put across the airwaves over the years, who knows? But quite a concerted effort, and it's teamwork. It's teamwork, and it's recognition of what does good look like, and where are we at? What does good look like? What's our opportunity? And and defining together what are the next steps, as you've really articulated nicely. So thank you.
Thank you.
Hey, don't change those announcements. I mean, if you think about it, those are public service announcements for anybody that's in the building.
Yeah.
That stroke's important, sepsis is important. And if people are sitting in the cafeteria, they need to know that sepsis is a big deal.
Yeah. Length of stay, mortality, the morbidity is just huge. Yeah, thank you.
So thanks again, everybody, and as I said, maybe before she came in the room, we'll look forward to Dr. Heisterkamp's presentation next month, and please join us. It'll be an interesting, rich Friday to have our surgeon colleague present to us. Thanks again, and have a nice weekend.
Thank you.